my nipples are completely flat. How am I going to nurse?
We're not nipple feeding, we're breastfeeding.
Talk to your baby. Talk to your baby about their birth process and let them know.
It's painful. And they're like, I don't like this. I don't want to do this.
Each breast did something specific for that child.
And she gave me a big hug. And she said, thank you, Dr. Olga, for saving my child.
And they're only drinking water and eating because they need to make milk, not because they thought about themselves. They're still bleeding, for goodness sakes.
Oh.
One visit.
Oh,
and
wow.
she got her to the breast.
Welcome to the Ask the Dentist podcast with Dr. Olga Dolghier, where your smile meets your overall health.
I'm very excited and thrilled to introduce both of you, my guests at my podcast, Ask the Dentist, where I invite different specialties and I love to have conversation about what we do. So I'm going to start with Nikki since you're next to me first.
Yes, absolutely. Yeah.
So Nikki is a registered nurse in IBCLC, which is internationally board-certified lactation consultant. Also, I found out that you are specialized in intensive care help for infants, right?
Yes.
So that's amazing. And my second guest is Dr. Renee Thompson.
Yeah.
She is a chiropractor. And both of my guests today are actually business owners,
Yes.
which is a very big thing because we are all female business owners.
Right.
Yes.
Yeah.
So there is a lot of up and downs. We know how business goes.
Yeah.
It's true.
Yes.
But we're supporting each other.
Yeah.
That's what matters.
Yeah, absolutely.
And Nikki is the founder of Gentle Lactation Touch consultation for IBCLC, technically for babies, to help with nursing.
Mm-hmm.
And Renee is the founder, I love the name of your practice,
Thank you.
Agape, right?
Yep.
Family Chiropractor.
Yep.
So Agape, I looked it up.
Yeah.
It's a God of love,
Yeah.
right?
Yeah. Unconditional love.
Unconditional
Yeah.
love. When I looked,
Yeah.
I was like, oh my God, what a
Yeah.
great name.
Yeah. So there's 5, it's Greek, and there's 5 types of love according to the Greek language. And so that one means unconditional. So for us, that unconditional, every time we see our sign, say our name, answer the phone, it reminds us that when a family calls in, our goal is to meet them where they're at, to serve them, to love them, and to help give them a hope and a future. And if that's with our help, great. And if that's referring to other providers they need in their life as well, then we'll do that. So
That's
we're meeting
amazing.
them where they're at to
I
help.
love the name. I love it. So let's talk about what unites us. So believe it or not, we are facing challenges as moms, as doctors. And I remember being mom myself for the first time,
Yeah.
which was 25.5 years ago
Yeah.
when I had my first one.
Nice. Looking good, Mommy.
Yeah.
Looking good. Nice.
I have to count in my head how many years.
Don't worry about it.
But I have a question. I had no idea that there is a support for moms. So my first question would be, because I know you, Renee, is Webster-certified, right? That's a special certificate for prenatal care for moms.
Yeah.
And I remember being myself a very young mom. I was barely 24 years old. And I had no idea what to do, how to do. I remember that little infant they brought to me and they would try to nurse. I remember struggling for a little bit and they gave me a formula right away. How is it now, Nikki? Are they still doing the same thing in the hospitals?
They do. We really want to encourage breastfeeding. We focus on first latch. The golden hour is really, really important. So when I do prenatal visits with my moms in my office, it's one of my favorite things to do. We really focus. I talk to them about what to expect at labor, what to expect after delivery, the golden hour, the breast crawl, that initial 1 hour that you get. I always say, ask everybody to go out of your room. This is your moment to bond with your baby and your partner and have them be with you. And you watch the baby do their own breast crawl. A lot of people don't realize that the initial, when the baby's born, that the Montgomery glands on the areola secretes amniotic fluid scent. And it's what makes the baby have that first amazing latch.
Oh my goodness. I didn't know
So
that.
that's one of the things we always focus on. And in my prenatals, that's one of the things we go over so many different varieties of things of positioning and that first latch and the breast crawl and the golden hour. And I try to empower moms going into labor and delivery so they feel like they have a little bit more basis and they're not so scared and not understanding what to do on that first latch.
First time.
Yeah.
And and Renee, you help moms who are expecting to. So your beginning is before baby was born. We can before.
Yeah.
What does that certification you have?
Yeah.
What does it provide?
Yeah. So actually, when we look at that, we're actually thinking even pre-conception if possible, which sounds kind of funny, but really for mom, if we're looking at fertility, we also want to make sure that about 3 months before she tries conceiving, she's looked at her lifestyle, supplementation, her sleep patterns, whole foods, water, to be sure that when she ovulates, she's actually, dropping the best egg. We joke about it, like giving the best egg, the best genetic potential she can for that baby. And so we're having this beautiful, healthy rhythm of cycling and hormones, and that takes at least 3 months, giving the best egg. And then supporting mom with chiropractic care through her pregnancy. Oh, wow. So that does a few things. The big thing is it keeps her nervous system more clear, more balanced. She can feel less in a fight or flight state and more calm. So that's really supportive of her, really supportive of baby. And then if we think very simply, like even just structurally in the pelvis, if there's any rotation or torsion in the pelvis, that will actually twist or torque on the uterus, on the round ligaments, cause SPD, lightning crotch. Like any woman who's had that, when I say those words, they know exactly what I'm talking about, right? But that allows space for baby to have the best positioning. What I find with a lot of babies post-birth who come out with tension and then in addition might have oral ties or tethered tissues, then if I'll commonly ask the mom if they're stuck in one pattern, were they always on one side of your pelvis? If I didn't see in pregnancy, were they always stuck on one side? And they're like, how'd you know? They were always in my right hip. Or, they were born sunny side up or all these things. And so we're actually working then with intrauterine constraint issues that baby kind of developed with, in addition potentially to any oral tie issues. And that just compounds the issue for the little ones.
So everything starts way before we already have a baby.
Right.
Wow, that's amazing. Yeah. So we provide this whole kind of support and care. I know how important it is on my side to talk to mom, to give them advice, how important lifestyle, like you mentioned, is for oral health and for overall health.
Right, exactly. Yeah.
Because everything is interconnected.
Oh, absolutely.
I think there is such a big kind of compartmentalization in our healthcare in general. That I love that we can kind of look at the big picture nowadays and kind of unite everything. Yeah. So after baby was born, what kind of help we can do for moms? Nikki, what can you provide? When do you see babies for the first time with mom?
I love to see the baby within like 2 to 3 days after.
2 to 3 days.
Yeah, 2 to 3 days after being discharged from the hospital. As much as the lactation consultant at the hospital or the nurses at the hospital want to provide the best care they can, a lot of times they're short-staffed. And it's just how life is. That's how hospital life is. So I like to get to them as soon as possible so that I can build a foundation for them, help them to get a better basis of positioning, find out why things are hurting or if they are hurting, right? It's usually typically people that come to me, they're saying their latch is hurting. They're having pinched nipples. They are struggling getting the baby in a right position. The baby is fussy. We're seeing all these things, won't open their mouth wide. They're having sucking blisters. So those are things that I'm looking at. And that's why I love having the whole interdisciplinary team of you, Dr. Olga, and Dr. Renee, because we see the baby as a whole and we see mom as a whole dyad. So we treat all of them together. And I think our pediatric care team, that is I call us all, is I think our foundation really helps. And I love the words when I will do an initial consult. And one of the things I do is I look for tethered oral tissues. If we have all of these symptoms going on, body tension, lip sucking blisters on the lips, we are having a narrow gape, they're not opening their mouth, mom ends up with lipstick nipples, or their pinched
There's
nipples,
a lot of symptoms.
right? Painful latch, a fussy baby, a baby that hates the car seat, all of these things. Or if I ask my trick question with parents is, does your baby take a pacifier? And it's typically, oh no, he doesn't like it. That tells me that they're probably not elevating their tongue and they're not able to cup their tongue. So it's the last thing I look at. I look at latch and everything else first. And then I look at I do a full functional oral assessment to see what's going on. And then that's when we definitely refer over to Dr. Renee to have baby worked on, a little bit of body work to see if the fascia can be helped and the condyles and everything else working to get that baby smoother, and having you assess oral restrictions. And just seeing my favorite phrase after frenectomy, post-frenectomy, even an hour after post-frenectomy and having body work is this what latch is supposed to feel like? My favorite statement. And I don't know how many times I've cried with moms because they start crying because the baby latches, and we start seeing just a beautiful jaw gliding and tongue cupping, and I'm doing oral habilitation prior to getting them ready.
It's amazing. Let's focus on common questions.
Okay.
Sometimes we get questions from mom, very untraditional, even new moms who are planning to have a baby. Can everybody nurse, or is there anatomical challenges? For example, I get the flat nipple question a lot from friends. My nipples are completely flat. How am I going to nurse? I'm not going to be able to nurse because my nipples are flat. Let's talk about
inverted.
nipples.
That's the other one. Or inverted. Right.
I had a good friend in Colorado. She literally struggles so much with that because she completely had inverted nipple, and she even was saying that, I'm like, this is not my field. It was a couple of years ago. I don't know how to help.
I think the biggest thing that people need to realize and remember is we're not nipple feeding, we're breastfeeding. So we're aiming to pull the nipple and the areola into the mouth. If we can get a wide gape, the tongue cupping, the body loose, and we have extension in the baby's neck, and we lead in with the chin, we should be able to get a baby breastfeeding.
Gotcha. Yeah. What about when you see this mom with a new baby for the first time?
We do like to see them sooner than later. So in that first to second week of life is a really good time to just check. Just assess. There's so much that happens, like I said, even just when they're in utero. And we all know like those ties in the mouth are forming from early on. They're fully present by 20 weeks. So by the time a little one is born, I think it's always really important to talk to parents about the fact that those ties have been present in their little one for about 20 weeks, plus or minus a little bit. So it sounds kind of funny, but these fresh little ones who just came out, they have an existing pattern. And so we need to retrain that pattern. And so as far as like getting to the breast and latching and moving, there's certain things as a chiropractor, especially in the infant or pediatric patient, that we look for. And that type of assessment, that type of adjustment is very, very different than how an adult gets adjusted. So if people are only familiar,
that's a good idea to explain, because I'm sure you get a lot of questions.
Like, absolutely. Like if you've for babies, I know. I'm like, we're not just swinging them around by their toes. So first of all, like if you've ever been to a chiropractor and you're an adult, and that's what you're familiar with chiropractic care, it's not that for a baby. It's exactly what it should be. It's baby size and it's baby specific. And There's no more pressure than you put on your eyeball. It doesn't look like a lot. It doesn't need to look like a lot. There's no thrust or pop or click. We really enter their nervous system very less to more, so it's not overwhelmed. A lot of the babies we see tend to be in a fight or flight state. So
very
some
tense.
Yes.
signs of that are
Absolutely.
like they're holding their head up early right after birth, and inevitably someone's like, oh, they had such a strong neck. And I'm like, they were just in zero gravity. Nothing should be strong,
Or,
you know?
or look at them rolling over
Or look
already.
at them roll to their side, or their hands are tight, or, you know, but they can't, or they're arching. Well, then they can't like get close and snuggle in and feed. And then their hands don't relax when they feed. And
Why are they so tense when they're born, some of the babies?
yeah, some of the babies go through a lot during their birth process in all reality. You know, some of them aren't positioned well, or they got stuck in the canal, or maybe potentially mom could have been moved around a little more in labor, but she was stuck in one position. And so baby had a hard time getting stuck. If they have a shoulder or getting down the canal, if they have a shoulder dystocia and they get their shoulder stuck on the way out, if their head was tipped or tilted, if they came through the canal really fast, or if they were in there a really long time. So any extremes
So
in life.
all those,
Vacuum, forceps,
which is
C-section.
pretty much everybody.
It's a
Like-
lot. Yeah,
like
it's a lot. Yeah, birth, and moms know that. I mean,
Yeah,
moms know that.
of
We go
course.
through that. We feel all that pressure, and baby's doing that with their head. And, you know, and really to a certain degree that should be what happened. That little cranium should be squeezed and then fluffed back out. And that's a nice, you know, set for their nervous system. It activates it on the way out, just wakes everything up. It's beautiful. And then we take this beautiful big breath and all these rhythms begin in the body, and it's lovely. But sometimes it can get hung up on the way. And that little cranium that gets squished on the way out, maybe part of it gets fluffed back out, but part of it gets wedged.
Okay.
So certain things we see that affect latch that way are things like the temporal bone. If
Yeah.
it's internally or externally rotated, that'll actually pull the jaw to one side. So with occlusion, it'll actually set it to the side. Teeth on that side actually wear more. You'll see the nose even kind of pull that direction a little bit.
You see,
So,
I didn't know that
yeah.
as a dentist.
Yeah.
That's good for me too,
Yeah.
because I see
Yeah.
a lot of cross bites,
Yeah.
and sometimes you see them early.
Yes. Yes.
Like I see 1-year-old,
Yep.
and they're already not symmetrical.
Right. Or that bite strength is different on one side or the other.
Yeah.
Or the frontal bone, actually, if you look at a little one's forehead, the middle of their forehead is actually an open suture. It's the metopic suture. And,
Yeah.
and so that the forehead actually behaves early on as two bones. So if one of them is kind of rotated forward or back, that actually will affect jaw occlusion as well, like the strength of closing your mouth. But watch those babies, because when they yawn, that jaw will deviate to one side or the other.
Oh.
Well, if we're trying to suckle and I open my mouth and it goes one way, and I try to close my mouth and it's not strong, or it pulls to one side, right? Or I can't tuck my chin, or I can't extend my head, or my head's always turned one direction. You know, if you even try to turn your head and swallow,
Oh, yeah.
like that's difficult. So these poor little ones, when they come out, if they have any of these little
Oh, that's
roadblocks
right,
in their nervous system, then
Absolutely.
then we can't get to that.
Huh.
So-
What about C-section babies?
Yes.
Okay.
Yeah, same
do,
thing.
Do we see any difference between C-section babies and
It's same thing.
Yeah,
It's
same thing.
how long
Yep.
they sat in the pelvis. How
Right.
long have they been there? Same idea. I had an example of a patient that we just experienced, Dr. Renee and I don't know, you don't think about this. This baby was a 35 weeker. And was spent quite a bit of time some time in the NICU, and came to me, and she was very angry. She was in that fight or flight, and we tried the skin to skin. She was absolutely refusing the breast. We did baby wearing, and we did baby wear with mom exposing her breast, and we have baby trying to latch. She was not having any of it, and I got her in to Dr. Renee, and the mom called me back. She goes, one visit, and she got her to the breast. She's like, she breastfed after seeing, and I'm like, oh my gosh, this is amazing. So we continued, and now this mom is exclusively breastfeeding. And I had a couple of visits with her, and I just said, she's in the fight or flight, and we need to get her into the rest and digest mode.
Yes.
And just one visit, a very gentle work with her, and it was amazing. And I just love seeing our team, all three of us, as teamwork, and seeing the changes that we're doing for moms and babies.
Yeah, absolutely. Yeah. And I love that actually, because when Nikki refers someone in, the strategies she gives them at home before they would even come in and see me are very complimentary and very helpful. So when that baby walks in the door, they've already learned a little safety of touch. like you were asking about the C-section or even forceps or vacuum, that does put a little one's nervous system into fight or flight. Now, when we talk about these things, we have to be really careful too, because most of the time when we use those interventions, it's literally to save baby's life or
Of
mom's
course,
life
yes.
or both.
Yes.
So, but it's hard. It's hard on a mom to think about that too. And mom guilt hits really hard and really fast. And so we have to be able to let some of that go and be like, you know what? Okay, I recognize that, but half of that isn't actually reality. You know, there's no fault here, but we have to still train the baby's nervous system afterward that like this world can be safe. You can be touched even if there's a spot from the vacuum, even if their first touch in the world was cold forceps or someone entering the womb for a C-section, where psychologically baby's not prepared to be touched in the womb until they come out. So they can perceive that as danger. And so we want to, again, bring them out of that fight or flight state. And I always encourage mom, talk to your baby, about their birth process and let them know, baby, we tried all these things. And then eventually, like, we just needed to get you safe and get you out. And so this is what we did. And honestly, that actually calms baby's system down as well. So again, not just thinking of one thing, but looking at that whole picture.
Whole big picture, what happened, how it happened.
Right.
Yeah, so it's more complex. It's not just the ties
Right.
in the mouth.
Right. It's not just structural.
Much more than just structural anatomical.
So, like the skin on skin, Nikki was talking about, having that oxytocin release and that calming and that snuggle, like that helps baby be like, okay, I'm safe, but I'm still stressed. And then we help remove that stress. What's very cool is when those babies do so well and they do so well so quickly, I always remind mom, that's them. Right? Like, I don't heal anybody but me. Like, we don't, like, when you cut your finger, like the Band-Aid, that didn't heal you, you did. You know what I mean? And it's good to put it in a safe environment, but you healed it. And, you know, so it's neat when these little ones do better. It's like, okay, that's your real little one. The screaming, the colic, the discomfort, the gas, that's not really them. What you're seeing now is like their true self.
And those are symptoms.
Cool.
That's one thing that always drives me crazy is when we get a pediatrician or somebody that comes back and says, well, your baby has colic. Well, is that a symptom or is it a diagnosis? Right? Because when we release we have body tension release. We have, and one of the things I see almost every time when there's a release of oral restrictions from you, what we see is reflex. It seems to typically get worse, but then it gets better. And what's happening is that body goes from that fight or flight to the rest and digest, and the body adjusts. And you start seeing hiccups go away instantly. Yeah. You see the reflex go away. And then you have these parents who are like, well, I was told to be put on medication for it.
We see it all the time.
We see it all the time.
You see this medical history, medication, or switching from nursing to completely different kind of formula.
Yeah. Or take them off because your breast milk isn't. Yeah. Right. But when we work together and we support the moms, then they feel like it's not them. I think like when you have a baby that's tense and they refuse to latch, mom is thinking, oh, he doesn't want me. That is absolutely far from the truth. It's far from the truth. And I always tell parents, the mom, I'm like, I promise you, when you do skin to skin, he doesn't push you away. He's just having to learn how to latch and to work and connect. It's not, but when he's skin to skin, he's very calm. So we have to take that approach that when, like you said, they're true them is when we connect and we find what's happening. We don't ignore, like using a nipple shield because the baby can't latch. That's just a tool, and we don't want that tool to progress and stay. We need to find out why. What's the root cause of something? What's the root cause of colic? What's the root cause of your baby not latching? Is your baby in this forward flex position? That's tension, right? So we don't eat in a hunched over position. We eat open. Right?
Positioning, I think, is such a big part of it. It is. Because a lot of times when you have baby for the first time, you just kind of adjust to it, but you don't have this big thinking process.
I have moms that come to me on their 4th child. They've never had lactation, and they're like, why didn't I know this before?
Absolutely. That's how I felt with my first.
I love, and it's funny because I'll have moms come in, I'm like, what are you going to teach me about lactation? Because I'm like, this is your 4th. But then you'll be surprised, even just pumping how the flange is completely wrong and how it's painful for a mom to pump, but we can make it so much better and make it more comfortable.
Explain us about that.
Yeah,
Some
that's a good one. Yeah,
that's
so
a good one.
you're-
Very interesting.
Yeah. So when moms are pumping, if necessary, if we can't get a baby to latch, or we have a mom that's got to go back to work, right?
Yes.
So they need to pump. So your big, beautiful pump comes with these very large flanges. It's all about marketing. So it's about, well, if we do it too big and it doesn't fit, you have to buy a smaller size, right? It's all about,
really?
Yeah.
Oh my God.
That's
Never
how it
crossed
is.
my mind.
That's how it is. So these poor moms don't know. And they're like, well, it comes with a 24 millimeter or a 28 millimeter. I never put a mom in a 28 millimeter ever. It's a waste of plastic. So moms think that that's the size they're supposed to work with. Well, it's only supposed to have your nipple gliding into the tunnel gently, and it's not supposed to have areola going down the tunnel. So moms don't know any better. They're getting sore nipples, chapped nipples, and they're getting, and it's painful. And they're like, I don't like this. I don't want to do this. So when they come to me, we size them. And we size their nipple and their base of their nipple. It's all about, is it comfortable and what is your output, right? That's what pumping is about. It's not about making sure. And the other thing, I just popped into my head, is I always tell moms, stay off of social media. Stay off of the mommy and me groups, because inevitably you're going to see the mom that shows, look at my 80 ounces I pumped today.
It's hard.
And it is.
hard.
Or my picture.
Is it the competition?
I think they just don't know any better.
Yeah.
These moms are
so they're comparing with somebody else.
And these moms that are oversupplying, they are putting themselves into oversupply and inflammation. And what these moms aren't showing on social media are the clogged ducts and possibly mastitis. They're not showing that side of it, right? So these moms are like feeling inadequate. 25 to 35 ounces in a day is average. And you should be patting yourself on the back for every drop, every ounce.
Every drop.
Even if you only are giving a few ounces a day, that's immunities you're giving to your baby.
Of course.
That's everything you're giving them for their brain growth, their body, their nutrients, right?
Yeah.
So I always tell moms, be proud of yourself for everything you're doing. But that's another thing that I do at Gentle Touch Lactation. The biggest thing I do is I'm making sure that moms are comfortable. Their mental health is protected.
That's another big topic,
Yes,
because mental health,
right.
we don't realize as mothers that we might have a problem postpartum.
Your mental health, it always comes first with me. We want you happy and well-rounded so that the rest of your family can be happy and well-rounded.
Yeah. And I just want to think about, like what you said about the immunity with the breast milk and pumping and all of that. And, having some freezer stores and having backups, that's a good idea. I mean, you should have some.
Right.
But we also have to recognize in that when a baby is nursing at the breast, that's a two-way street. There's a saliva exchange, right?
Absolutely.
Yeah.
So there's a couple different ways we make antibodies and help hand over immunity for our baby to support their immune system with our breast milk. One is you kiss them. Right? You chew on them, you kiss them, they're delicious. I think that's why women actually think children are like delicious and they're like, I'm going to eat you for breakfast.
I love the big smell. Big smell.
Oh, yeah. The best ever.
When they
best ever.
Right. But women are like that more than men. And I think that's a given instinct to us to like kiss your baby, because then your body will make immunity in that milk. So, right. So if you don't think if a baby's delicious, then something's off. But the saliva exchange, at the breast, there's a two-way street. So I just think this is miraculous, right? Like when a baby nurses, your body does a little lab test right at your breast, specific to that child. So in that next 24-hour period, your body is going to make the right amount of antibodies for whatever they're fighting. They're going to make the right amount of vitamin D, vitamin K, proteins, fats, all these beautiful things that baby needs, probiotics, all of that.
Customized.
Yes.
And
it's
customized.
Absolutely. It's custom for that baby.
Yeah.
And actually there's very cool imaging and studies where like, I remember seeing a picture once of a mom who was nursing her twins, and she had a breast per twin. And one of them was fighting a cold, wasn't feeling well, and she pumped. Well, the kid who was feeling well, beautiful, creamy, yellow, thick, rich breast milk. Other kiddo, same woman, same pump, different breast, green.
Oh,
Well,
wow.
that kid needed something different for what they were fighting. And I just think that speaks even extra to the amazingness of a female's body, that each breast did something specific for that child, right? So we have to remember that if we're have, 80 ounces in a few months, that's not a bad thing. Also, maybe take a nap, give yourself a break, but some women, there's so much, production happening. But we have to remember that 2-month-old, that 3-month-old, if we're saving that milk till they're 8 or 9 months old,
Correct.
That's different. That 8 or 9 month old need for fats, for proteins, for all of that is different
Yes, it is.
than what
It
you
is
need
different.
at the 2 or 3 months. So you want to mark the age. And sometimes I'll tell parents to mark, did they have sinus congestion? Did they have a cough? Were they pulling at an ear? Make yourself a note. Because if you pull that out in the future and you're going back to work and that little one's congested, you know what? And you have to pull some milk out, pull out the one that maybe has some antibodies to help with that later on.
That's
so
amazing.
those are
The
kind
other
of helpful little
thing,
things.
the other thing with that too is one of the things I always tell families is that direct breastfeeding is breastfeeding. Pumping for your baby and bottle feeding is breastfeeding. I always tell them to let that sink in. It is breastfeeding because it is breast milk going to your baby. And if you are pumping, exclusive pumper
for the saliva exchange.
Take the saliva and put it on your breast and into your nipples. It's going to go into your breast and help change the microbiome as needed.
Wow.
Yep.
The saliva of the baby.
Yes, saliva of the baby.
Yep. Swab their mouth.
Yes.
Put it on your nipple and areola. Pump and do that at least once in a 24-hour period.
Yes.
But if you can do it a few times, even better.
Yep.
Right.
A few times throughout the day.
Yep. And you're still custom.
So when we're pumping without the baby, our body doesn't know.
We're not getting
exactly
that saliva, right?
Oh, right. Wow.
So I always tell families, but
so there is a feedback mechanism between saliva and the
So that's why I always tell
amazing.
parents, you are moms, you are breastfeeding. But I want you to take that saliva and help that microbiome change.
Wow. That's interesting. How body amazingly
women's bodies are amazing.
And we can do a feedback loop on that. That's very cool. And after baby is born, I know mom can go herself through amazing stress. I think dislocation of
you name it.
You name it. Everything can be.
It could be their pinky toe. We don't know. Yeah, it could be anything. Yeah.
And the common belief, women just have to go through it and
suck it up.
Doesn't matter if your hip is hurting and you're not walking straight and you now laughing and peeing your pants.
Right.
So normal.
We're told that we're normal, right?
It's supposed to be normal,
right? It is not. No.
But it is not.
No, right. One of my biggest irritations, honestly, is when women are told, "Oh, you're pregnant. Just wait. It gets worse." Like somehow we're told we're supposed to fall apart. And I'm like, it's actually the exact opposite. We grow humans.
I know.
That's amazing. That's miraculous.
Body,
It's a superhero power. We grow other humans and then we feed them from our body. We shouldn't be miserable or falling apart. Now, granted, yes, relaxin levels are going to kick in. There will be different pressures and stresses on our body. Our center of gravity will change, but we're also made to be able to do that. So if we're supporting that system and from earlier on, the better, then all of those transitions are smoother. They're easier. It was years and years and years ago, but I had a woman come to me. One of the first times it really hit me in the face was when she said her sixth pregnancy, was actually more comfortable than her first. And I was like, because she was under chiropractic care.
Oh.
Yeah.
And she wasn't with any of the other 5.
Mm-hmm.
And I was like, are you kidding me? I just was like, this poor woman has done this 5 times and didn't know she could be this comfortable or functional. So again, and it depends on what did we accumulate in our life, right? What chiropractors take care of in the spine, what can interfere with the nervous system. It's called a subluxation. And so our primary subluxation is usually formed before 2 years of age. After that, anything else is compensatory in the spine.
Oh, wow.
So through that, we run, we jump, we fall, we learn to walk and we fall 100 times a day. You roll off the couch or fall off your bike or climb a tree and tumble, whatever it is, sports, we accumulate stuff.
Yes.
So one day as an adult, you lean over to pick up a pencil and you're like, oh my gosh, I can't stand up. It was just a pencil. And I'm like, it wasn't just the pencil, you know? So, and of course, like we don't want to
history.
Right. Or we take all of that into our pregnancy and we have all these changes through our whole body, which are beautiful, but we don't have the adaptability and our nervous system wasn't ready to fully support that, you know? And so we want to make sure that a woman's body is ready and has that support. From as early as possible. And that helps her and that helps her baby. That extends to her family, that extends to her birth process and to her recovery. So we always tell women, post-birth, you come in as soon as you feel comfortable. As soon as you feel comfortable leaving the house. I've had women be like, hey, I'm on my way. We are leaving the hospital. Or I've had women, where we go to their birth and we adjust during labor. Midwives have called and said, we're stalled out. Can you come check the sacrum? And we do. And then, a little bit later, labor keeps going. Or adjusted them at home post-birth because that's what we had set up for them ahead of time.
Because a lot of women have back pain after birth.
Yep, and pubic pain.
And
and then transitioning into nursing, we get neck, upper back, which affects nerve supply from the upper back, affects breast tissue health. There's definitely cranial work we do that affects hormonal systems for even prolactin, like from the pituitary gland. And so we want to look at that and keep all that supported and functional. Usually we hear from women after they're adjusted, one, I can breathe. I can stand up. My upper back feels better. My neck is more relaxed, because we're trying to get this baby to feed
ears, shoulders up to
here, position, and
absolutely.
And so Nikki walks them through these beautiful postures too, to be able to feed and like do some reclined feeding or side lying or bringing them up to you, all those good things. And so that's wonderful. But yeah, helping with that helps. But we do hear a lot of women say, oh, like in the middle of the night, like we can naturally kind of engorge a little more, have this swell of milk. And usually at night, they're like, oh my gosh, I got adjusted. Middle of the night, man, like 3 o'clock in the morning, they're like, boom. Like, it's beautiful. So it's not every time, but it is supportive. And so it's great. Like that's encouraging. And then they're like, I did it, so it's great. Yeah.
That's wonderful.
Yeah, it's very cool. Yeah.
And so the women who, for example, struggle after birth, they can seek chiropractic care.
Absolutely.
And that would definitely readjust and help them.
Yeah. And for their pelvic floor.
And for the pelvic floor.
You want to come back together and heal the right way the first time. And at 6 weeks, we are not done with that. We're just done bleeding and we have no infection. But that doesn't mean postpartum is over.
Right.
It takes time. And as long as you're nursing, your relaxin levels are still high.
But in our society, we like nursing, then we have to go to work, then
stress
come back. And a lot of women losing milk, right? Is very common.
Stress.
Is it stress?
Stress.
That's why?
Yeah, stress.
Food,
and
water.
Stress. And if they go back to work, they don't get the opportunity to pump as often.
Right.
I always tell moms, pump when your baby would be eating at home. If you can possibly do that. That's when we get into different styles of pumps, and I work with them on that to make it easier for them, but make sure it's still a functional pump to keep up with their milk.
Yeah.
Yeah.
That timing is important, working with your employer. Yes. And we watch for that too with moms who are under care. What is their stress level? Are they sleeping? We check on them. Like even if they're not a patient, but baby's coming in, mom's obviously an extension of that. But we check on them, and if they are under care, we're gonna check as well. But like, hey, how are you sleeping? How are you eating?
How are you doing? Yeah.
Are you getting minerals? Are you getting food? Important. Is someone feeding you? Like someone should be bringing you food, And then, what are some strategies or some ways that you can help, that we can help with that, because it can feel like a lot. And like Nikki said, the timing of the pump is also important.
Yeah.
Yeah.
The timing, their stress, making sure, again, going back to their mental health.
Right.
I make sure that I have, a counselor, a perinatal counselor also that I refer to, making sure that mom's taking care of themselves, making sure that they know that they're not alone, that
That's very
it's
good point,
okay
actually.
to
There's
ask.
so many moms you see and they're overwhelmed.
Right. I feel like I'm talking people off the ledge all the time, and it's okay. It's okay to cry. It's just a safe place in my office,
Absolutely.
But when I find that their anxieties, a little extra high, or their affect is a little bit flatter, I'm making sure that we're getting follow through with amazing care with counseling as well.
That's counseling.
Yeah.
That's very important.
Yeah.
Yeah, it is.
Yeah, and going back to what unites us.
Yeah.
Yeah.
Yes. Please.
The ties.
Yeah.
What do you, Renee? There is a common belief, Dr. Renee, that ties, every muscle surrounded by fascia, right?
Yeah.
And tongue is surrounded by fascia as well.
Yep.
And those fascias are interconnected. Can you elaborate on that? Can you explain the time, because when we release, one of the moments I had a probably 7-year-old boy, and I released his tongue. He was extremely tongue-tied, like tip to the ridge, technically, complete
At
ties
7. Oh my gosh.
at 7.
Okay.
And parents were a little bit reluctant to begin with. And then when I showed them, he literally could not cross the vermilion border of the lip. I was like, I have to do it. Right. Let's do it. And we released, and there was interesting reaction on the kid. He took a deep breath, kind of stretched out a little bit, and took a deep breath and said, oh, I feel better. Yeah. And 7 years old is this cute age when they can communicate with you, because you don't know, like 2-year-olds may not tell you, or infant, we can know with mom, but for 7-year-olds. So that was an interesting experience for me personally. I'm like,
Yeah.
And he actually kind of stretched out his neck after that, moved his head. So for me, it was interesting to observe, like what exactly. So explain us how fascia works. This is your field.
Yeah, absolutely. Yeah, totally. So it's kind of funny because we talk about different like lines of fascia in the body, or planes, or so there's front line, back line, spiral, all kinds of things. So, but it actually is one big piece. So how I explain it to patients usually when they come in is that your fascia is like one big piece through your whole body, like saran wrap, like a big piece of plastic wrap, right? So even if you wiggle your pinky toe, if I hold one end of my shirt and the other end of my shirt and wiggle it around or side to side opposite, even if I wiggle my pinky toe, everything in my body, all that fascia should respond. So the joke with fascia is it's one big piece and you tucked in muscles and organs. Okay, just tucked it into little pockets in there. So if I'm pretend again, I'm holding each end of my shirt and I'm twisting it opposite directions. If I put 2 fingers in the middle of my belly, right, and I pin those down, that's like a tongue tie or a lip tie. And so now when I try to move that shirt, I have an anchor. They behave like a fascial anchor, especially to your front line of fascia. So what we want to do is, if possible, try to get some of the torsion and twist out of the top and bottom of that shirt. How we do that as a chiropractor is we look through the body at all the fascia, but especially the really thick fascia. It's called dura, that wraps around your brain and goes down into the spinal canal. We want to make sure there's no torsion or twist in that, because that's affecting your whole nervous system. We want to reduce that. And if we need to, remove those ties out of the way. Right? There are some things in the cranium and in the mouth and in the nerve supply in the mouth that can actually tighten the muscles of the floor of the mouth that can actually mimic a posterior tongue tie, right? So we want to make sure that's functional. Or when they come in to have a release with you, if they need a little roll behind their neck and we're going to extend the neck and we're going to open the jaw, we want to make sure they have all the accessibility to that we can, so that it's easier for them to have the release and they recoil less afterward. So, but sometimes we need to remove those anchors and move them around. And when I send people into a consult with you, I'm like, listen, here's what I'm seeing. Here's what I'm finding. I think this is where we're at. I'm going to send you to this person also because she doesn't laser everybody who walks through the door. Because not everyone needs a release.
Not everybody needs a release.
Right.
Yes.
So, but we're going to work on some function. We're going to get some support. And those babies already start feeding better. They're more comfortable. They're less hiccupy, colicky. They sleep better. And then when they do the release, it's easier. It's smoother. And again, they recoil less and they transition better to learning to use their tongue. We're also restoring nerve supply to the area in the mouth. And that peristaltic wavy motion of the tongue. We want to make sure that's working properly. And so I usually tell them fascia, big saran wrap piece, it gets torsioned, it gets pinned or anchored down, and we need to remove the anchors and then retrain that pattern. Yeah. That being said though, I always want to remind people when we're retraining that pattern, it takes time. And Nikki uses this verbiage and I love it. It's a process.
It's a process.
It's not a procedure. It's a process.
That's a good one. Yeah.
I always tell parents too, if they're just a few weeks or a month away from a growth spurt or a new milestone happening, to just be patient. They're going to do all this work. We've cleared some tension. We've worked on their nervous system. We've released the ties. You've done the stretches. When they hit their next growth spurt, that tissue that again was fully formed by 20 weeks in the belly can pull back to their old pattern, even though they're so tiny.
Yes.
And so when that happens, don't be discouraged. They're growing quickly. It's an old pattern. We're going to walk them through that again. each time you help them repattern it, it pulls back less, and then they become more and more functional as they grow.
Yeah, because pathways in our brain, we're always trying to go back how it was before. We're trying to recreate. So
don't be discouraged. We're not going back to square one.
I see that, and that's what I reiterate with my patients all the time.
It's a process.
Yeah.
What about unique stories, guys? Have you had any kind of outstanding story? I'm sure you have
absolutely.
bag of
I'm like,
I'm like, which one?
I know. Yeah. Oh my goodness.
My brain is just
a few years ago, one comes to mind, and we co-cared this person. It was a few years ago. This little one literally screamed for like 24 hours a day,
baby.
almost. Yes,
Baby.
not okay.
I know what you're talking about.
So much so that Nikki, my now has become my friend, right? Which is amazing. She does such a good job. And so my wonderful friend over here, in the kindness of her heart and her NICU nurse and all the heart and all the things, this baby was so much, these parents were so just tattered.
Yeah.
Do you remember what you did?
Oh, I know exactly what you're saying.
Do you want to say it or do you want me to say it? She was like,
they didn't have family around.
No one. They had
nobody.
They had no one.
Mom
and they
dad
had
the
seen me probably 2 visits maybe by that time.
And she saw it in their eyes.
And they just were so beaten down. And I said to them, I said, do you trust me? And they said, absolutely. And I said, would you two like to go and get yourself some coffee? I hadn't even finished the sentence and they were out the door.
Right.
they
And
left the
baby with me.
She's like, I am actually qualified to keep him alive.
It was on a Saturday.
Right.
The office was dark and I walked the halls with this baby for 20 minutes. And they felt guilty when they got back. They took too long. And I just walked the halls, held the baby.
Kept him safe.
Just so they could have a few minutes. They had never had a moment of peace. And this baby was a lot.
Yep.
But we worked together.
Yeah. So Nikki called and she's like, this is what just happened. And she's like, because, we're very specialty in our office. Perinatal, pediatric, and cranial function is very much an extra. And it's all postdoctorate work. Okay. So it's kind of funny, but because of that, like sometimes our exams can get scheduled far out. So Nikki called and she was like, hey, this is what just happened and I need this baby in ASAP. And I don't remember what happened, but we figured it out. I don't know if I stayed longer. I don't know. It was several years ago, but like we got this kiddo in. And again, these poor parents, right? And so they're okay, Nikki told us some stuff and now like occasionally we can get him to sleep or he'll at least sleep in our arms. And we've been doing some of the stretches she showed us. And I'm like, fantastic. That's good. That's great. We start working, we start adjusting. And this little one calmed down so much and their lives, like from that co-care, like changed. And that they saw Dr. Olga.
They did. All 3 of us saw.
Yes,
we
did.
I
remember the crying.
It was a lot of work.
Yes.
So it's funny. So they actually moved in this last year out of state, but we stayed in contact. So mom went through a second pregnancy. So whole family ended up coming. They're like, I don't know what this voodoo magic is, but like we want some too. Like first, like yes, your nervous system also needs to come out of fight or flight. Let's work on that. Yes.
Yeah, because it affects the couple.
Oh yeah, absolutely. Yeah. So and then so mom had her second baby and was under care during pregnancy and all of that, and had worked with Nikki and had all this support. And so I remember, they brought little one in, second one so fresh, and they're like, this baby's so calm. And they're like, we didn't even know with our first, like we knew how hard it was, but we had no idea, having that support through pregnancy, having the support of an earlier and knowing and knowing how to put baby on the breast the first time, signs to look for, like they were just like night and day.
Yeah, they started care earlier. That was amazing. The key. I think sometimes moms like, I think I'm doing okay. Yeah. I think it's all right. But then they realize 2-3 months in that this isn't right. Pain shouldn't be happening. My baby shouldn't be this tight.
Arching, shaking their head, preferring a breast.
So when we get a hold of them, and it's always my sad statement when I ask mom, I'm like, why didn't you come sooner? And they're like, because I didn't know any better. I didn't know about a lactation consultant.
No one told them.
Exactly. That's why I'm creating this podcast, because people don't know.
Right. Yeah.
And when it's your first child having 3, I know every single kid is different. And when you're there for the first time, you have no idea what to expect. And your normal scale of normal can be very wide. My scale of normal, I remember my last child, I actually, before I got into tongue ties, I had her right before my residency.
Yeah.
So
Yeah.
extremely stressful
Yeah, girl.
time. So she was two months old, and I was focused on pumping, and I was nursing her as well. But she was a colicky, fussy, very difficult baby. Very difficult. I remember even Adrian, my husband, would sit on those yoga balls, and he had to like jump half a night,
Right.
because that's the only way she would sleep.
Right.
Yeah.
She was
And I
looking for
had to
attention
have
override.
very, very difficult.
Yeah.
And actually, later on when I got into tongue ties, because again, not everybody understand the tension, the fascias, what we describe, how it affects the baby. And then at the age of 8, I looked at her mouth. I was like, oh, wait a second. That is extremely tongue-tied. And she was interesting because she did have a white palate in addition to that, but she was tongue-tied. And then I released her. And she kind of was interesting to observe personal experience.
Yeah.
How did she feel? She actually had pretty kind of mild procedure. She didn't complain, and she's a complainer.
You made a good point about like tongue tie and not knowing it.
Not knowing
One of the things that I hear a lot that comes in my office is my doctor told me that my baby can extend its tongue out. It's not tongue tied. That
and
is
I know why they say that.
Yes.
Because they teach us in dental school. They teach us if you can cross vermilion border, the lower lip. Again, nobody specific how big your lips are. What type of chin you have. Then you're not tongue-tied.
So I explained. So I always explain to my patients. I said it's about elevation. It's not about so much about extension. It's about, can the baby elevate the tongue, separate from the jaw, and pull your nipple and your breast tissue into the mouth.
And lateralize.
Right. And lateralize. Absolutely. So whenever I hear the statement that if your baby can extend its tongue out, it's not tongue-tied, I always tell them that's somebody who is not completely educated in tongue ties, and let's do a full functional oral assessment. I think that and I asked them, I said, did this person that looked at your baby, did they get in their mouth and did they elevate the tongue? And they're like, no, they just said that the tongue can extend. So there's so much more that people don't realize, that you really need a full functional oral assessment, because you didn't know, right?
I didn't know. Well, we covered very little in dental school, and they show you like extreme case. Extreme case when tip of the tongue attached to
anterior.
On a lingual. Anterior. Complete ties. They show it to you. They're like, this is not normal. And everything else you can compensate. That's pretty much what they teach you everywhere. I don't know what they teach medical school. I'm sure even less than what we
And you just said the right thing. I always tell moms, we want competency at the breast, not compensation.
Yes.
So you just said that. Everything else, everybody can compensate. You shouldn't have to compensate for anything. You shouldn't have to use a tool.
Like we don't
you
want to be
shouldn't have to use a tool to thrive at something, right? It should be able to be functional and be properly used, right?
Right. Yeah, absolutely.
Yeah, absolutely. It's such a big part of it. And because we see one of the memorable experiences was, I don't remember if I shared with you. I think I did. We released a child a year ago, I would say. And then I saw her at 1 year old checkup, because you should see dentist at the age of 1. And mom gave me a hug. And because I see a lot of patients, I remember some, but not everybody.
Right.
And she gave me a big hug. And she said, thank you, Dr. Olga, for saving my child from feeding tube. And I was like, from feeding tube. And then after that, I started to remember that she could not latch on, she could not nurse, she could not properly, she would not gain weight. So she was on the verge of going straight to the ER.
She was going to failure to thrive.
Failure to thrive. And they were saying either you're going to get feeding tube. That's the next step.
We do that.
And we did the tongue tie on that particular baby. I'm not saying that works for everybody, but we did that, and it helped that particular child. And I was like, oh my gosh, about to cry. Because that's
we cry with our patients a lot.
Oh, absolutely. Definitely. We got tissues right there, man. We do. Because it's real and it's hard. And these poor women have struggled, and they are fighting. They are postpartum. They are exhausted. They might have other kids at home. They're barely getting enough water, and they're only drinking water and eating because they need to make milk, not because they thought about themselves. They're still still bleeding for goodness sakes.
Oh.
You know what I mean?
Or
And
the
they're-
C-section mom
and
that's
they're not
healing from a
sleeping,
major
right.
abdominal
and
surgery.
she shouldn't even be carrying that car seat,
Right.
but they're going around the world doing everything they can
Yeah.
just so their baby can feed. That's hard. So they need to get the right people on their team to be like, we recognize this is hard. We see you. We hear you.
Mhm.
This is your reality. And we are going to walk next to you and we're going to get you in
yeah.
touch with the people, all the people you need on your team. Because it's not just one person. It is a team.
It's
Yeah,
a team.
To bring that
interdisciplinary
together
team, right?
to support you, right? You
Yeah.
and your baby and your home. Like,
Right.
Yeah, and
Right.
it's so important. I remember, Nikki, we saw a little girl and you heard the heart murmur.
Mhm.
Everybody missed it.
Yeah.
That's
And
your NICU.
Nikki's-
Yeah, girl.
Yeah,
And
I
Nikki-
always do. I tell people, from being a neonatal intensive care nurse, I always do head to toe on my patients, always.
Yeah.
And I'm very careful to make sure I'm listening and auscultating for the heart and the lungs. I've caught heart murmurs multiple times. One had to have open heart surgery.
That one, I remember it was
Had
a
one,
tetralogy.
yeah.
She picked up tetralogy.
That's amazing.
Nobody picked it
Yeah.
up before.
That's amazing. Yeah.
I don't know
Yeah.
how.
I don't know how it got missed. Laryngeal Malaysia.
Yeah.
I've had that. Had
a big
one
one,
baby
yeah.
had to have surgery for that.
Mm-hmm.
But yeah, I will always do head to toe. I'm always going to be a nurse first, and
Because you're intensive care.
yeah.
helps.
It's just inbred in me.
Yeah.
It's just what I
Yeah.
do.
Right. Yeah. Yeah.
So, but I just love that we are coming back to us, all three of us. I just love the changes we've made for our baby. It has just been watching it grow over the years and seeing the changes for the
Yeah.
moms and the babies and seeing and getting the comments back later of how much things it's changed their whole journey or saved their journey. That is, and I always tell people, I'm only your guide. It's you and the baby that are able to do all the hard work. I just guide you and help you. And that's just one of my favorite things to do.
It's true. It's amazing. Right.
It's amazing. Yeah.
Yeah.
Especially when you see them later on, how it changes life,
Right.
kind of set them up right for the right future.
And success.
Yeah.
And I was reading about TMJ. I
Yeah.
noticed
Yeah.
you do, and it was
Yeah.
interesting for me because for us as a dentist,
Yeah.
TMJ is like not much we can do.
Right. Oh, there's so much you can do.
Yeah,
now.
you can
I
do.
know. And again, that's
Yeah.
right. That's what are
something
you
we
told,
tell.
right? Because
That's-
you can
that's what we were
only
taught.
know what you're taught, right?
Mhm.
Until
Yeah.
until you get out of school and you're like, oh, there's this whole other world. Let's keep
I know,
learning.
exactly,
That's
right?
That's
Yeah.
right. And that's why. That's why I just
Yeah.
that's why we have 3 specialties, because I was curious and I'm like, there's got to be more. You know what I mean? Like, it's kind of funny, but yeah, TMJ is amazing, and there's so much upper cervical spine, cranial function, facial bones that play into that and into that function. So again, when we look at that, big players are, again, temporal bone and frontal bone. We already talked about how that can move the jaw side to side or cause it to deviate. We want to look at the musculature, of course, that opens and closes the mouth.
Yeah.
And you already know this, but the palate is made of 4 different bones, right? So in the front, you have your 2 maxillary bones and your actual palatine bones. So when we're little and all those little sutures are open in the head, we have this big suture in the middle of the palate called cruciate suture.
Yeah.
It looks like a cross. Well, on the sides of that, way back by your top teeth, there's a sphenomaxillary suture.
Yeah. There's lots of them.
Mm-hmm. So your sphenoid bone is a key player in the head. So we always want to make sure that's functioning properly. And that's basically a butterfly-shaped bone that sits in the middle of your head, and your brain kind of sits on it. But because of its shape, it can torsion. It can move up or down. It can move laterally. And when it really gets torsioned, you'll see things like plagiocephaly. If it gets tilted, you can see things like brachiocephaly. So those head shape issues, we want to look for that,
I
right?
remember, yeah.
But because of its location in the skull, right in the center, it connects to every cranial facial bone except for 2, nasal and lacrimal. So that sphenomaxillary suture, getting that sphenoid and those greater wings of that sphenoid moving properly is a huge player. 9 out of your 12 cranial nerves pass through sphenoid, including ones to the mouth. So even if we're thinking like glossopharyngeal, like that, we need to make sure that's clear. We need to make sure that vagal nerve supply is clear. The vagus nerve calms your system, calms your GI tract, takes you out of fight or flight. So there's direct things we can do that release and clear that nerve supply and literally change the mechanics. But all of that super affects how the TMJ closes, how it rotates, how it glides, how it comes back to set in the joint, if it's being pulled one direction or the other, if it's clicking or popping.
That's very interesting because we were taught in dental school. So technically, TMJ, if usually it's a young teenagers, girls, sometimes boys, but mostly females around puberty. That's when we see for the first time TMJ complaints. And I do see in the practice.
Means it got bad enough to show up and we kicked in hormones.
Got bad enough.
Which amplified,
Which amplified it, right? Because the receptors, estrogen receptors are in the joint itself.
It's a lot happening.
Yeah. So a lot is happening. All of a sudden, I see this girls. And technically, the official form of treatment is mouse guard. The night guard. But night guard, I can't put on a teen because they're growing. So I cannot stop the growth plate from expanding. So technically, there is no symptoms. I say sometimes we send them to TMJ specialists for pain management. I think they do steroid injections in the joint. But what is the alternative? It's actually would be a very, very hot conversation, hot topic to discuss because I would say 50% of girls would have clicking and popping in the joint. And me as a provider,
they need to come see you.
I don't know what to say in this case.
So naturally, like, you know, chiropractic care. And I'm not saying that just because I'm a chiropractor, because I'm not saying all chiropractic care takes care of that or treats that. There's definitely fascial attachments and dural connections in your upper cervical spine, especially at C2 and C3 that affect TMJ function, especially C2, right? Goes through the head. But then there's also things from your palate that reach all the way back to that occiput. And so we want to make sure those things are clear. So you need to find someone who will work with your upper cervical spine, but that's not the top of our nervous system. Our cranium is. So you want to find someone who specifically does cranial work and facial work. So around the time you're saying, we actually get more of our adult skull formation around the age of 12. And then again, hormones kick in. Usually it's the same time in females that you see when they hit puberty, when like a scoliosis will show up. Their parents will be like, oh my gosh, they put on a bathing suit this summer. And we were like, holy cow, look at your shoulder blade sticks out and one hip is high and all the things. So a lot changes in the body at that time. And then we don't get our fully kind of set cranium until around the age of 25. Which is around the same time our sacrum fuses and around the same time we get logic brain. Right. So there's huge. It's a big, right. There we go. So there's a lot happening. So that being said, though, even though we have more of the adult cranium, there's still so much function and mobility in there to be worked with that if you can gain that function at that time, even better before a little girl starts cycling, because then her body's going to go through so many stable, unstable, changes through the month, that it's good for her to get that ahead of time. But really what we want to try to do is get these little ones close to birth. If we can get to them before 6 weeks old, it's a lot easier to get them back to the breast. It's a lot easier to get that function in their skull. It's a lot easier to get that development. I mean, shoot, the posterior fontanelle is going to start closing around 4 months old. And so in the cranium, so we want to make sure there's function in the cranium before 4 months old. And it mimics, that's a funny time because that people will be like, baby's head looks flat. Their pediatrician said the back of their head's looking a little flat. I'm like, their posterior fontanelle is closing. Give it 2 months. It's going to look better. And that's not the parents' fault. This is, they were told this information from someone that didn't know. So if we can get to them ahead of that, better. But if they're already at that age, then they need to seek someone who specifically works with function of not just the TMJ. It's a whole cranial system that is affecting the TMJ.
So it's exactly. It's not just one joint.
It's not just one joint. It's never just one thing. Yeah, exactly.
Therapy
just like when people talk to you and they're like, oh, so you just release that thing under the tongue, and you're like, I mean, yes, but no.
There's more to it.
There's affects through the whole body.
Yeah. There's much more to it.
Much more to it than that.
Yeah. And again, that's not like a judgment. Like I'm not making fun of that. You can't know what you don't know.
Right.
And as soon as you tell people, and it also affects this, they're like, oh yeah, that makes sense. But you can only, even us as providers, at first we could only know what we learned in school.
Yeah.
And then afterwards and living life and having kids and continuing ed and you learn.
So technically TMJ girls with these problems can see a chiropractor who specializes in craniofacial adjustment.
Yes.
And that would be.
And here's the other thing. If you have a TMJ issue, frontal bone is likely going to be involved. The frontal bone also mirrors the pubic bone in the body. You have certain cranial bones that mirror other bones. Your temporal bones can mirror your ilia, like the big winging bones in your pelvis, your occiput and sphenoid junction. They actually move together. And and help move that flow of fluid around your head to wash and cool and debride your brain. Debride your
Mm-hmm.
brain. But the occiput and sphenoid can mirror sacral function. Frontal bone can affect pubic bone function. So in those girls, again, especially before they start cycling, we want to make sure this is stable and check through their pelvis as well. Because if now we're going to start cycling, we want to make sure their pelvic floor is also stable, just for their own life. But especially if they do want to carry a child later, and not everyone does, we want to get that right the first time,
Of course.
right?
Yeah.
And not be making that up. But even if they don't, like I always tell people, like if you're taking care of this whole system, I'm like 75-year-old, you was like, thanks. Appreciate that. That was really helpful.
Yeah.
You know what I mean? And so
Yeah.
like looking
Yeah.
back in time,
Yeah.
so like it's all planning into the future. But yeah, those are definitely things to look for.
That's very interesting because you get some information, but then clinical practice and you want to help and there's
Right.
limited what you can do. And piece of plastic in the mouth, I mean, it's helpful,
Right.
but you...
Well, and if there's
just-
ever a mold, I always tell people if you're going to have anything molded to your mouth, holy cow, come here first for a while. Let's get things stable. And I want to see you the day of right before you get the mold. Because if we're having anything custom made for the mouth, that's where you're going to be held every night. And if we're held in that compensatory pattern, we're never going to move
I
toward
see
function.
that.
Yeah.
Yeah.
So we need to get as much
Yeah.
function as we can and then hold it there. And if it still feels like at some point that starts holding us back, we're going to take it out. We're going to keep improving function and we're going to remold. We're gonna,
Yeah, that makes sense.
yeah.
Yeah,
Right.
Makes sense. It's a good idea. Maybe even after orthodontic care.
With it or before
Or
it or,
with that.
or avoiding palatal expanders if possible. Like that can be done in a lot of cases, especially as babies with a high palate. It's actually your maxillary bones internally rotated and it's an abutment joint, right? They don't bevel, they don't interdigitate or they connect. They just sit right next to each other. And so we want to make sure that can move and the tongue can get up there and continue day to day to move that out. So we're not forcing a situation.
Yeah, the palate is interesting for me because on my side, I see different type of ethnicities.
Yes.
And sometimes you see certain ethnic groups, I would say like North European regions, narrow palate, always, even with no ties, very narrow. I think it's just historically because of the congestion of the nose and everything else, they already have those changes, epigenetics, and that's what affects them, epigenetics. But then you see, it's interesting, regions which may have some Native Americans in them, they have the widest palates and they can have complete tie.
Yeah.
Complete tie. I'm looking at the tongue. I'm like, how did you grow this big palate?
That's interesting.
I don't know.
Yeah.
Because if you talk to orthodontists, the genetics actually kicks in and the way the bones are growing is determined pretty much with genetics. So of course, soft tissue plays a big role and you can manipulate it to a certain extent. But when Renee is talking about those growth spurs, that's when actually that genetical makeup what they have. And it's always puzzling for me because when you're practicing, you're observing and in your head, you have certain patterns. Okay, if you see this, you should see that. And sometimes when it does not match, it's very interesting.
Why? Right, yeah. But then you have to ask. If you don't ask why, then you're not going to keep helping the people you need to help.
Right. Yeah.
So, and we see the same thing, like in the craniopath world, we see that a lot with the Asian population. So what's natural, what's normal, what's functional in an Asian population, like you were saying, Northern European, a high palate.
High palate.
Yeah, and you said congestion, which is exactly right. That maxillary bone, when it's internally rotated, you have congestion, but nothing comes out. But you
The
hear
baby's always selling for congestion.
Yeah, you get gray circles under the eyes. Nothing can drain. So we want to work on that because we also don't want the ears to end up backing up.
Yeah.
But again, like in the Asian population, it is normal and functional for the back of the skull to be a little more tucked in or a little more flat. So, again, around 4 months, several years ago, she's 3 now, about 3. So, but several years ago, this little one was about 4 months old. Mom's coming in and dad is of Asian descent and mom is not. Baby's back of the head tucked in a little bit. Posterior fontanelle is starting to close, so it's going to mimic that anyway. Cranium's moving really well. We've gotten a lot of function in there, and she's being told she needs to be assessed. She needs to be assessed. They're saying she needs a helmet. They're saying the back of her head is flattening. And I'm like, well, let's look at these couple things. Let's look at these indicators. Let's measure some stuff and let's take into account her genetics. And I'm like, has anyone talked to you about her being half Asian? there's function there. We don't want to be yanking that back out, or we could actually cause a problem. And she was like, no one said that. And she's like, you know what? I want to wait. I see this function. I see her doing better. She's hitting her milestones. She's feeding well. You know, everything was turning into a really good rhythm, even at a time of a sleep regression. And, you know, come 3 years later, like they made it through, and even the pediatrician was like, oh yeah, she ended up not needing a helmet, you know. Good.
So just by
good job on the tummy time. And I'm like, yes, tummy time's important. But exactly right. And I'm like, had they slapped a helmet on her, would they have caused stress in her nervous system? The likelihood in her case was yes. Instead of creating function and allowing her head to round out how it's meant to, it could have caused a lot of stress in her specific case, in her nervous system. Yeah. And so, you know, the mom was, you know, actually really proud of herself, and she should have been. I mean, she trusted her mom gut, and that's my thing. I'll give you information, and I'll give you the information to the best of the ability I have. And you gather your information from all the people on your team, and you decide and trust your mom gut. It's specific to that child. Yeah. So don't let anyone force you one way or the other. You trust your mom gut specific for that child. It's a gift.
For sure. Yeah. Yeah, and sometimes you see Asian population is very interesting. They are predisposed to having class 3 bite, we call it, when mandible is very forward, because they have maxillary deficiency a lot of times. And then they have this kind of rotation, and sometimes it's only surgical. I mean, we're trying to fix it earlier, but we cannot really, and back to your questions, probably would be a good idea to start with.
Get some function
initially and see where we're growing. Because then if we develop class 3 and post-puberty, there's not much you can do.
It's hard,
It's hard. It's the only surgical approach at that point. Yes, ladies, that was very cool.
It was fun.
I love the teamwork, though. I do. I love working with you guys. I love that you guys, you know, own the information you've learned so well, and that you've continued to also like search and reach out. And I feel the same way. Like I always want to learn from people who are good at their craft, who are good at what they do, and who genuinely care about people. It's like, I love working with you guys because you actually care about the person behind the name on the paper. You know? And I love that. Yeah.
Who needs what and why they need it. We're truly trying to help.
Working as a team, we've just seen so many successes
I know.
over the years. It's just been amazing to watch the moms grow, their confidence grow.
Yes.
The babies, just be successful within breastfeeding, bottle feeding, unwinding, right? Unwinding and just becoming themselves.
Yeah.
I think now we see second generation of babies. Not second generation, but I think second baby for
second baby, third.
Oh, for sure.
Second or third, because we've been doing it long enough. And I think moms are getting better.
Recognizing which helps all of it, incling eventual airway function and all of that.
Definitely.
So it's long lasting. It's far reaching into their life. Yeah.
There's so much behind it, you know, and coming and seeing us and being able to help answer some questions, just to not feel alone, right?
Yes.
I want moms to come to us and feel like, at 2 a.m. when I was looking you up, I saw
it's always middle of the night.
Yeah, always the middle of the night.
Yep.
And they see the stories of other people that have been to us, right? I love that they're like, I'm not the only one. I'm not failing, right? And I can be successful at this. And
a lot of times.
And I like that there is a team out there to help me, not just give me, I feel like I always tell families, when you go to Best Buy or, a store, you buy a TV, they give you a book, an inch thick, right? And they hand you a baby at the hospital and go, good luck.
Right.
You know what I mean?
Here's a human. Good luck with that.
Right. Figure it out.
Right.
So now they know that they have a team that can help them. And I think that's really, really important.
I think it's extremely important because you see moms in different stages of success or failure. And our goal is to bring them to be successful and for baby to grow well, healthy life. That's why we're working together and providing the best care we can possibly do.
Yes.
Thank you, girls, so much for joining us.
Thank you for having
us. I love chatting about it.
That was fun. And we might do it again with the new information. Sometimes something new comes up. And our listeners, guys, if you like what we do, if you like my podcast and want to see these guests again, ask all the questions, because that was a very hot topic about nursing, about breastfeeding, and about the future, even TMJ we talked about. This is very, very interesting, and we have these experts who can answer all the questions. So if you like us, please share this podcast with your family, your friends, and like us, and stay tuned for more videos. Thank you so much.
Welcome to the Ask the Dentist podcast with Dr. Olga Dolghier, where your smile meets your overall health.